So, madam, we are live now. Shall we start?
Yes.
Okay. So, good evening, doctor, and all the participants. I, Shumon, on behalf of Shield Healthcare, welcoming you all today with another very interesting session with Dr. Ritu Santwani, madam, on ovulation induction protocols in IUI. So it is our honor to introduce madam, although madam doesn't need any kind of introduction, but it's my formal responsibility to introduce ma'am very well. So madam did her MBBS, MD, FICOG, FIAOG, MRCOG, and madam is the senior obstetrician and gynecologist, infertility specialist, and she is the co-founder of MAM, board member of WSCG, and founder and CEO 360 Degrees Healthcare Studio. So with this short introduction, I request madam to take over the session, and meanwhile I request all the participants, thank you very much for joining on that interesting webinar on this ovulation induction protocols in IUI, and I request all the participants, please drop your questions in the chat box in the platform, so that after the talk we can have a short discussion on this topic with madam. So thank you very much, madam, once again for your valuable time on Shield Connect platform, and over to you for further proceedings. Thank you very much.
Yeah, thank you, Dr. Suman. A very, very warm welcome to all of my dear friends who have joined all across the geography. I'm able to see some of my friends have joined from the Africa, some from the Egypt, and some from Arab countries. And of course, my dear friends from India too. A very, very warm welcome to all of you. So friends, today I am going to discuss a very, very important topic. What are the ovulation induction protocols for IUI? I know everybody is not doing the IVF, but IUI everyone is doing. So I made this presentation very simple. At the end, we can discuss what the protocols you are using. So be free to communicate. In between, you can drop your questions, and later on we can communicate. Something I will learn from you, something you learn from me. So without wasting time, now I'm starting the presentation. Just a second, I'm getting some messages that YouTube live is not coming. Just a second, I will check. Chitra, can you check? It's going on YouTube?
Chitra?
Yes, ma'am.
It's going? Okay, just a second. Okay. I hope slides are visible.
Yes, madam. Yes, madam.
Yeah. So thank you, Shield platform, and special thanks to Dr. Prachi, Dr. Suman, Dr. Nishan, and of course my dear Chitra. Always they are very helpful, and always they take the responsibility to that the program should be live streamed on the YouTube, so those who missed can be later on benefited. So friends, as all of you are aware, my all presentations, whether the national or international, will start with the Durga Mata Stuti. या देवी सर्वभूतेषु चिकित्सा रूपेण संस्थिता नमस्तस्यै 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 नमो नमः. So as I told, we are going to discuss regarding the ovulation induction for IUI. So how to go for this? So now the topics which are the headings, subheadings which I am going to cover: the improvement of the follicular growth, increasing the number of follicles, treatment of anovulation and the better timing, improvement of luteal phase. So now why this C.O.H is coupled with IUI? As we all know, it provides the more number of follicles with good quality. Timing of HCG injection predicts the ovulation better, so as to schedule the IUI near the ovulation time. C.O.H offers more over for the fertilization and implantation, and hence increases the success. And C.O.H corrects the subtle endocrinopathies which blocks the ovulation and implantation. So as we all are aware regarding the male factors for this, in the IUI, the retrograde ejaculation, impotence or ejaculatory dysfunction, hypospadias, hypospermia, non-liquefying or highly viscous semen, subnormal semen parameters, seminal anti-sperm antibody, and unexplained infertility. Regarding the female factors, the vaginismus, cervical hostility, ovulatory dysfunction, mild endometriosis, allergy to seminal plasma, unexplained infertility. While what are the indications in which the donor semen has been used? So the azoospermia with testicular failure, severely abnormal semen parameters, hereditary disease in men, severe untreatable RH isoimmunization in wife, repeated failures with IVF or ICSI, single women and the lesbian couples. So now which protocol we have to use? The protocol that should be simple, cost effective with minimal side effects and the best success rates. Patients requiring the ovarian stimulation or induction can be categorized into the two groups, as we all know. Regarding the ovulatory, just a second, I don't know what. Yeah. So regarding this, in these patients, there is an established ovulatory pattern. Multiple studies have shown the improved pregnancy rates with ovarian stimulation in these patients as compared to non-stimulated natural cycles. So aim in these patients is the multiple follicle development. The slide is not moving. Yeah. So while in the cases of the anovulatory, the aim is for the ovarian induction, 20 to 30% cases of the female infertility among this category. In the anovulatory patients are further divided by WHO into the three categories. The group 1, the hypogonadotropic hypogonadism. Group 2 is the PCOS, and group 3, ovarian failure. In these, our aim is the monofollicular development. Here, I want to share with you all these days, whatever the patients we are getting, especially I am getting all the patients who the Google savvy, they come and read. And yesterday only the one patient told me, ma'am, though I am a patient of PCOS, the earlier doctor where I have visited, they tried to make the so many follicles. Why they are trying to make the so many follicles? That's why my IUI is not getting succeed. So now, depending on the stimulation protocol, what about the success rate? In the cases of the natural cycle with IUI, the success rate is reported 3.3. With CC, it is reported 9.5. And with the letrozole, it is reported up to 10.6. With the CC and HMG, it is reported 13.3. While with HMG and IUI, it's reported the 17.26%. Just a second. Parvati, मेरा मीटिंग चल रहा है, उधर जाके बोलूं. Number of follicles, pregnancies per cycle. If the one follicle is reported is 5.7%, 2 is 13.6%, 3 16.3%, 4 or more 13.9. Higher pregnancy rates with 3 pre-ovulatory follicles has been reported. So here we can see the number of follicles, how it affects the success of the pregnancy rate. But in our practical scenario, we are trying to make not more than 2 to 3 follicles are enough for the success of the cycle. So what is this? The pre-induction checklist. The day 2 FSH, more than 10 milli-international units per ml is suggestive of low ovarian reserve, antral follicle count, ovarian volume, AMH, or the HSG and lab. So now what are the regimens we are using for this ovulation induction? As we all know, the different drugs what are available, the CC, Letrozole, Gonadotropin, CC with Gonadotropins, Letrozole with Gonadotropins, Gonadotropins with GnRH analogues, Gonadotropins with GnRH antagonists, and of course the tamoxifen also. In some patients, we are using the tamoxifen also. So now we will take one by one. In the cases of the spontaneous, the cumulative pregnancy rate per couple was 33% for IUI and C.O.H. And 18% for IUI alone. Studies have shown that C.O.H. has independent positive effect on the pregnancy rate when combined with IUI in young patients without a prior pelvic surgery and with good post-wash semen quality. C.O.H. doubles the IUI pregnancy rate. The study has been supported. You can see down I have mentioned. The study has been presented by the Hendon-B, Falcon, Halleck, and Nelson. So now coming one by one, yes, as we all know, Cyphene or the Clomiphene Citrate that we all have used, still using. So if you want to know my opinion, in my opinion, I prefer CC more compared to the Letrozole. I'm finding the comparatively good results with the CC, the most widely used, simple to use, minimal side effects, and cost effective. Now, how this drug acts, as we all are aware, this CC binds to the estrogen receptor and depletes the receptor concentrations, where in the estrogen negative feedback interrupted, and it causes the more follicle are rescued and multiple follicles develop. So depletion of the estrogen receptor in pituitary and hypothalamus due to prolonged stimulation, estrogen feedback loop gets interrupted and FSH secretion increased, leading to multiple follicle growth. So dosage, as we all are aware, the 50 to 100 mg per day for 5 days. Studies have shown the dosage up to the 200 mg per day. There is no difference in pregnancy rate, whether CC is commenced on day 2, 3, 4, or 5 of the cycle. Although there is perhaps a tendency to multiple follicular development, the closer the agent is commenced to menses. So studies have shown the outcome after the CC, the pregnancy rate 30%, failure, no pregnancy despite the ovulation 40%, resistance, no ovulation 25%, anti-estrogenic effect up to the 5% cases has been reported. Now coming to the another drug which these days everyone is using, the Letrozole. So Letrozole shows the excellent result in the cases of the CC resistant or CC failure, associated with thicker endometrium and increased stromal blood flow, and thereby providing a better uterine environment more favorable for implantation. Compared to CC, Letrozole has been shown to have higher pregnancy rates. So here we can see the mechanism of action for the Letrozole. Sorry for this slide, It inhibits the aromatase in ovaries and peripheral tissues, reducing the estrogen levels, which in turn causes a negative feedback, being the active stimulates the hypothalamus pituitary axis. GnRH release produces the FSH. FSH-mediated stimulation of follicles, rising estrogen level from the follicle suppresses the FSH, leaving a single dominant follicle. So dosage, as we all are aware, the dosage 2.5 mg per day, starting the cycle day 3 to 7 and maximum up to 7.5, because different protocols we are using with this Letrozole. In some patients we are using the extended Letrozole protocol up to the 10 days also, in which we gradually increase the dosage, or in some patients we are using the 2.5 mg up to the 10 days, or in some patients 5 mg, starting with 5 mg for 5 days, and then the remaining 5 days I am giving the 7.5, of course with the follicle monitoring. So in comparison with CC, the higher rate of monofollicular, no direct anti-estrogenic adverse effects on endometrium, shorter half-life, and lower serum level of E2. Extended letrozole therapy. As we know, friends, a recent study conducted by the Badwe et al. Extended letrozole therapy 2.5 mg daily from day 1 of menses for 10 days was used for CC resistant PCOS women. Higher number of patients ovulated. Number of dominant follicles were more. Pregnancy rates were significantly greater and no extra cost to the patient. So the letrozole step-up protocol has been reported by the Medpelli et al. In this protocol, the letrozole was administered. In this, the step-up doses consisting of 1, 2, 3, and 4 tablets of letrozole daily on menstrual cycle days 2, 3, 4, and 5 respectively, the multifollicular development and higher pregnancy rate. So once we go through the literature, there are so many protocols has been reported with the use of the letrozole. Yes, but of course we have to do the proper follicle monitoring and then we have to decide about the protocol. So friends, here we can see the comparison between the CC and letrozole. The CC, the larger follicles early in the cycle, cystic follicles. In this, the poor blood flow to the follicles, thin endometrium, due to poor blood flow to the endometrium and luteinizing unruptured follicle chances are incidences are there. While with the letrozole, larger follicle size early in the cycle, we do not give the trigger till the dominant follicle is more than 20 mm to improve the oocyte maturity. Perifollicular blood flow is good. Endometrium thickness and vascularities are also reported normal with the letrozole. Now coming to the next is the gonadotropins. See, once we add the gonadotropins, of course the cycle cost is increases. But if you ask me my preference, yes, I prefer to use the gonadotropins. Yeah. So the indication is CC failure, letrozole failure, or in the WHO group 1, hypogonadotropic hypogonadism. The studies have shown from the Cochrane data 2007, long back they have reported the gonadotropins might be the most effective drugs when IUI is combined with the ovarian hyperstimulation. So now to use FSH or HMG administered daily from early in the menstrual cycle, monitoring with USG or hormonal assays is mandatory. Trigger the ovulation with HCG when follicular maturity is attained. Significantly improve the pregnancy rates from IUI in contrast to the natural cycle IUI. And the risk of multiple pregnancy is of course there. So the advantages with this gonadotropins is the high efficacy, ovulation rate more than 95% per cycle, conception rate 20 to 30% per ovulatory cycle. While the limitations with this, the serious complications can occur, multiple pregnancies, as we all are aware, twins in 25% and higher order in 5% has been reported. Ovarian hyperstimulation syndrome, long-term complication, ovarian cancer, require the intensive monitoring in the specialist center and it is expensive, that we all are aware. So now choice of gonadotropins depends on the day 2 LH, FSH and estradiol levels. If LH increases, the FSH containing gonadotropins are indicated, while if the FSH level is more than 10 milli international unit per ml, LH plus FSH used for the ovarian stimulation. For ovarian stimulation in the patients with hypogonadotropic hypogonadism, the combination of FSH and LH is used. Though it is mentioned, but every time we are not going to do the test for the LH and FSH in every patient in the every cycle. Some things we have to judge clinically also. So now what are the different regimes are reported with the gonadotropins? The conventional regimen or the low dose step-up regime or the step-down regime. So here, friends, we can see the chronic low dose step-up regime in which starting with the 37.5 and then to 75 and then 112.5 and then 150 and then the trigger while in a step down start with 150, then to 112.5, and then 75. Means from 150 to 112.5 when the follicle size is more than 10 mm. While the conventional regimen, I am in the favor of the conventional regimen, in which I find the good results. So giving in the dose of the 75 to 150 international units per day. And then accordingly, once the maturity is done, then we give the trigger. So conventional regimen, the CC resistant or CC failure cases started from day 2 or day 3, 75 to 150 national units per day. Serial ultrasound monitoring. Day 8 serum estradiol has been reported. Widely accepted protocol. Pregnancy rates are reported up to 30%. So friends, though it is reported to go for the day 8 serum estradiol, but in my practice, I am not doing just a thing. So that all depends. So many things, as I earlier told, we judge clinically also. So now the low dose step up regimen useful in the PCOS patients. The aim in these patients to find the threshold level of FSH, which will lead to the development of a single pre-ovulatory follicle. Less complication but unphysiological as FSH level is high, very high in the late follicular phase compared to the natural cycle. So now coming to the step up protocol. So the low starting dose 37.5 to 75 units per day. Stepwise increase in subsequent doses. E2 and USG on day 7. Day 8 E2 if more than 200 picogram per ml or follicle size more than 10 mm. We have to continue the same dose. If the E2 or follicle size is not achieved on day 8, you can increase the dose by 37.5 international units per day. So in my practice, I am deciding by the ultrasound. So now coming to see, friends, this we had gone to the step up protocol in which we have started from 37.5 to 75, and then we have gradually increased after seeing on the day 8 whatever there's a follicle size. Now the step down is in the step down, the HMG and FSH 150 international units per day from day 2. Continue till the dominant follicle become the 10 mm on USG. Then we have to decrease the dose 112.5 international units per day for the next 3 days, and then 75 international units per day till the time of the HCG. So now coming to the another regimen is the CC with gonadotropins, the sequential use of CC followed by FSH or HMG. CC 100 mg 1 daily from day 2 to day 6, then FSH or HMG 75 to 150 international units on day 6 and 8, and TVS on day 8. Then addition of FSH or HMG can be done. So these are the different protocols. Again, I want to emphasize there is nothing like some tailor-made protocol. Everything we have to decide that how your patient is responding. Sometimes some patients respond with the lower dose very good, and sometimes the patients, though we give the higher dose also, till also there is a no response. So the advantages of the CC plus HMG, the higher pregnancy rate than alone with the CC. More cost effective, the dosage of the gonadotropins is reduced. Lesser multiple pregnancy rates than with the gonadotropins alone. Lower incidence of OHSs as compared to the conventional regimen. This study has been also supported by so many others. This references I have taken from Human Reproduction Journal, 1993. Then the studies are coming regarding the use of the letrozole with the gonadotropins, the good alternative to CC in patients with unexplained infertility, undergoing gonadotropin stimulated C.O.H cycles combined with IUI therapy in a prospective non-randomized study by Mitpelli and Kasper it was shown that aromatase inhibition with letrozole reduced the dosage of FSH is required for C.O.H without any undesirable anti-estrogenic effects. So friends, how many of you are using the letrozole along with gonadotropins, and how many of you prefer the CC with gonadotropins, and how many of you are using only the gonadotropins? Please do write in the chat box, so later on we can discuss. So please do write. I'm able to see the 61 participants are there. So please do write in the chat box what you are using, which protocol is preferable to you, and you are getting the good results. But the pregnancy rate was achieved also significantly lower in the CC and FSH group, 10.5% compared with the letrozole and FSH group, 19.1%. And FSH only group is the 18.7%. These are the studies has been reported. So along with the letrozole and FSH shows the more good results. Now coming to the another protocol is a GnRH analog with gonadotropins. In almost 15 to 20% cycles of CC or HMG, due to multifollicular development, the estradiol increases the premature LH surge, which leads to the cycle cancellation. To avoid this endogenous LH interference, exogenous gonadotropins and GnRH analogues are used for ovulation induction, mainly useful in IVF. Recent Cochrane reviews has conducted that GnRH analogues do not significantly improve the pregnancy rates in IUI. Now, what about the GnRH antagonists? So, studies have shown that GnRH antagonists act by competitive inhibition of GnRH receptors, which results in rapid decline in FSH and LH levels, and thus preventing the premature LH surge. Can be given in a single dose or daily dose regimen. Among these, which protocols has been mentioned? As we all know, the Lübeck protocol, in which the gonadotropins are started as usual, and antagonist is started when the follicle reaches a size of 14 mm or from day 6 of the stimulation onwards in a dose of 0.25 mg per day till the day of HCG injection. So here we can see once the follicle size reaches the 14 mm, we can give the antagonist from day 6 of stimulation onwards in the dose of 0.25 mg per day till the day of the HCG injection. Another is the French protocol. The gonadotropins are started as usual, and a single dose of 3 mg of antagonist is given when the serum level is about 150 to 200 picogram per ml and follicular size is 14 mm. Advantages of antagonist protocol allows the manipulation of the follicular development so that the IUI can be avoided at pregnancy weekends without any detrimental effect on the pregnancy rate. Compared to the agonist, it is relatively simple and inexpensive. There is no suppression of estrogen and the effects are easily reversible. Antagonists are associated with lower rates of OHSs. So this is the advantage. Once we are using the antagonist, the chances of the OHSs are less. So now coming to the follicle monitoring. As we all know, by the day 2, by the TVS sonography we are doing to rule out any other dominant follicle or corpus luteal cyst. Serial TVS from day 8 to look for the follicular development number and size. Normally the follicle growth 2 to 3 mm per day helps in determining the exact time to trigger the ovulation, prevents the OHSs, endometrium looking for the thickness and appearance, and the triple line of the ET, as we all know, more than 9 to 10 mm is the ideal. Serial serum estradiol levels. In the natural cycle, the serum estradiol levels will correlate with the development of the dominant follicle. In the stimulated cycle, it reflects the total output of all developing follicle irrespective of size. Sometimes the problem occurs at the inconvenience cost and daily prick value is more than 200 picogram per ml. The good response mainly used in gonadotropin and cycle day on day 8. So now when we have to be very attentive and what the important time. So when more than 4 follicles of more than 16 mm or more than 8 follicles of more than 12 mm. So we have to do the serum estradiol levels. So if more than 1500 to 2000 picogram per ml, we have to cancel the cycle. If more than 1500 picogram per ml, use the GnRH analog to trigger the ovulation. Urinary LH assays. So premature LH surge is known to occur in 20 to 24% of the patients undergoing the ovarian stimulation after the leading follicle reaches the 16 mm. The LH surge can be detected either by doing a daily blood or urinary LH assay. Once the leading follicle exceeds the 16 mm, when LH surge is detected, injection HCG is given and the IUI is planned. So because so many patients ask about us today, so the timing of IUI, as we know, either by the confirmation of ovulation or after the 36 to 38 hours of the HCG administration. So now question comes, is the HCG is necessary? For this, so the studies have shown the HCG injection is necessary as the LH secreted by the body may not be adequate enough to induce the necessary maturational changes in all oocytes. If there are many follicles in the ovary, numerous urinary LH kits are available to detect the LH surge. They are easy to use and are cost effective. So I tried to make the slide simple, focusing on the only on the IUI, and later on if want we can take the another lecture series for the stimulation protocols for the IVF also. So I'm stopping the sharing. Yeah. So let me see what the comments we have received.
Thank you very much, ma'am. Many questions we have received in the chat box. So
okay. We will take one by one.
Yeah, sure. From Dr. Asha, Mr. Madam. Also, I request participants also, sir, please unmute yourself, and if you have any query, you can directly ask me.
I'm not able to see the questions, doctor.
Madam, the first question is
yes, I got it.
Yes,
got it.
Sure.
Yeah. Thank you, Dr. Suman. Yeah. Yes. Hi, Dr. Asha. Thank you for joining. Single dose letrozole 20 mg. No, sorry, I haven't used any time single dose 20 mg. So you tell me if you have used and how the results you have found with the single dose of 20 mg. So are you using the 2.5 mg ke 20 tablets or you are giving the 5 mg ke tablets? How you are using, Dr. Asha? Let me know your opinion, or is anybody else has also used? So let me know regarding the single dose. I haven't used for this. Yes, letrozole with HMG, good results. Dr. Narottam Rath has written, no dominant follicle in the natural cycle, but letrozole alone, the follicle becomes the 24 to 26 mm in the day 13. What to do? Dr. Narottam, let me know that what dosage of this letrozole you have used. You have used the 2.5 or 5. So then accordingly, I can help you. And in these patients, have you done the day 2 of the AFC and antral follicle count? Okay. These are the different answers. Yes, different protocols everyone is using. Yes. 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 Yeah. Hi, Dr. Dinesh. Yeah. In some patients, if 10K is not working, yes, in some patients, I'm giving the repeat dosage of the HCG also. While now the studies have shown the combination also, you can use this with HCG along with the leuprolide. And third protocol, in some patients, I am using this recombinant HCG. जिनका normal urinary HCG से नहीं हो रहा है, उनका recombinant HCG से definitely rupture होता है. This is my personal experience. Let me know others' opinion also. So because in the same cycle, if the 110K is not giving the result, again I will repeat the dose. And some, of course, we have to counsel the patient properly. Otherwise, if by giving 2 doses also, if the egg is not rupturing, in the next cycle, I'm trying the recombinant HCG. And if the patient is ready for that cycle also, yes, of course, I will try. In some patients, I find the very good results. Yeah. Yeah, hi Yukti. Which gonadotropin are you using in your practice? I am using both. In some patients, I'm using the HMG. In some patients, I'm using the FSH. So that all we decide. I told you that there is nothing like such tailor-made protocol. Accordingly, we decide. Dr. Beena, hi. Thank you for joining. Do you use cabergoline? Cabergoline for which patients? I want to specify. Please, will you specify? Yeah, hi, Dr. Chinmay. Thank you for joining. Is letrozole from day 5 or day 2? Any of the protocol you can use either from day 2 or day 5. Preferably, I'm using in my practice from day 3. I'm using day 3 and I'm starting with the 5 mg. I am not using the 2.5. मुझे मेरे patients को 2.5 से कुछ result ही नहीं आता है. और I can say patients when are coming to me, उससे पहले वो बहुत सारी जगह जाकर आए होते हैं. So I have to give the protocol definitely, which is something different and will give the good results also. Okay, one new message has been received. Let me see. Yes, yes. Hi, Dr. Beena. Yeah. Yes, I'm using the cabergoline. If I find, yes, there are multifollicular development in that patient, yes, I am using the cabergoline. Yes, the studies have shown for the cabergoline also, if you go to the Cochrane, there are different protocols has been mentioned. So in some patients, I am giving this 0.5 mg for 3 consecutive days. While in some patients, I am giving the 0.5 mg alternate day up to the 7 days also. Yeah, good to see Dr. Shilpa also. Hi, Dr. Shilpa from Bhopal. Yeah, good to see. Okay, Dr. Asha, thank you for enlightening us. Sorry, I have not used. Is anybody amongst us has been using this Letrozole 20 mg? So please drop your comment in the chat box. So that will be grateful for everyone. Yeah, hi, Dr. Chinmay. Do you use double IUI after 48 hours? No, Dr. Chinmay, see, I always do the IUI after confirming the ovulation. So the studies have shown for both, either after 36 or 48 hours after the trigger or after confirming the ovulation. So I am always doing after confirming the ovulation. Double IUI only in the patients with the where the severe male factor is there, only in that patients. Yeah. Acha, okay. Yeah, Dr. Narottam, as you told, ki after giving the letrozole, you are seeing the always in the. So for what I suggest, you can first down regulate your patient for 2 to 3 cycles with the OCPs, and then you try the letrozole. Definitely, I think you will get the better results. Of course, your patient must be taking off this myonisitol. Yeah, in which cases, yeah. Yeah, hi, Dr. Dinesh. Dr. Dinesh, the program has gone live on my YouTube channel. I think you are a member of our academic group. So, others, you can put my name. You can see on this for this recording what you are saying. Program is yeah. Yeah, hi, Dr. Shushila. Yeah, Dr. Shushila. Yeah, see, regarding, yeah, thank you for joining. Dr. Shushila is writing. Just a second. Yeah. Dr. Beena and Dr. Shushila, see, both of your questions are almost same. In which cases we do the dual trigger and how do you do? see, in every patient, not going for the dual trigger. Sometimes the patients are coming to me कि हाँ उन्होंने पहले कई बार, sorry I will speak in English, so many friends have joined from across the geography. So sometimes the patients are coming to me that they have earlier taken the urinary HCG and there are no results. So in that patients I am preferring for this recombinant HCG and getting the good results. Yes, now in some patients, some patient means the patients who are having a high grade of PCOS. In some patients, still if the result is not coming and patient is having some other high risk factor, in that patients, I have tried along with that the leuprolide also, the results will come. I can share with you the studies also if you want. I can put in the academic group. I think I will take one lecture that how the trigger के लिए भी मैं lecture एक plan करूंगी जिसमें I can show you all the that what and what we can use, what are the indications and how we can use. Yeah. I think we have wind up with the questions, Dr. Suman.
Yes, ma'am. Yes, so.
Yeah, one.
Waiting. Okay. Appreciation message, ma'am. I could see.
Thank you, friends, for joining.
Thank you very much, all. And madam, one request again from anomaly scan lecture, ma'am. Yes.
Anomaly scan lecture I have done with Dr. Kuldeep Singh, sir. Dinesh, have you missed that lecture? Dr. Dinesh, I think you have missed that lecture, huh? I have already done that lecture. You can go through my YouTube and you can see that lecture.
Another question I could say that how many menstrual cycles in CC is considered as failure?
Just a second. Again, please you repeat. I'm not able to.
Okay, ma'am. For how many menstrual cycles is CC is considered as failure?
This is if the studies have reported more than six cycles. If you're not getting the results, then either the CC resistant or the CC failure. So, but in our practice, we are not waiting up to the 6 cycles. So patient utni der mein dusre consultant ke paas chala jayega. If you can see up to the 3 cycles also I'm telling the maximum by the 2 cycles you have to see and decide, because those where the patients can afford the gonadotropins, I can suggest that better to use the gonadotropins along with this CC or letrozole. So the results are good, though the cost is there, but the results are good. उतनी ज़्यादा cycles आगे खींचने से अच्छा है कि 2-3 cycle में ही patient को result आ जाता है. So we will wind up for today. So friends, now coming 2 weeks, my series are starting on the cancer. Next week we will do on the CA ovary and the ovarian freezing also. And after that, we will do on CA endometrium. For 2 weeks, I am focusing on the oncology. And then I think I can plan one lecture on this for the trigger. So we can plan one lecture on the trigger where we can show all the details. So thank you once again for those who all have joined. So we will wind up with this today, and thank you, Chitra, too. Yeah. Okay, we will wind up today. Bye-bye.
Thank you very much, madam, for this nice talk and addressing all the queries also. And in future also, we'll be very happy to organize such a nice session with you, ma'am. So thank you very much, ma'am. Have a good night.
Yeah. Bye-bye. Good night. Yes. Of course, Yukti, we are covering the fertility preservation also. Bye-bye. Bye, Dinesh.
Thank you very much, ma'am.
Yeah, bye.